Good morning, everybody. It's 10 o'clock, so we're going to get started. We have a lot to cover today. Welcome to DDAP's Technical Assistance Series. Today, we're featuring a Campfire chat, strengthening provider practice and expectations across levels of care, and we're featuring representatives from Pennsylvania's behavioral health managed care organizations, and they call them BH-MCOs. As we go on, just to shorten that term. We're glad you could join us for today's discussion. Before we begin, I'd like to review a couple housekeeping items, including the Wiretap Act. Today's session is being recorded for training and/or record-keeping purposes. So by participating in this session, you are consenting to the recording, retention, and use of this session. If at any time you have a question, you can put that in the question and answer chat, and we will do our best to respond. For this webinar, we may not get to all of the questions during this time frame, but we will record them and make sure that they get answered once we post the webinar. But if you would like to ask a question and you end up doing so verbally, just please note that you are consenting to the recording, retention, and use of your statements recorded as part of this session. So please exit this call now if you don't want to be recorded, and you will be able to review this video in its entirety on the DDAP webpage in the near future. Our learning objectives are listed on the screen. They reflect what we hope you'll take away from today's discussion. I'm not going to spend too much time on the slides so we can get moving. Today's agenda is also on the screen. We'll begin with a brief overview of our presenters and the scope of today's discussion before hearing from each of our MCO partners, and then we'll conclude with a facilitated Q&A. We're very fortunate to have representatives from each of Pennsylvania's behavioral health managed care organizations today to share their expertise. Joining us are Anita Kelly from Magellan Healthcare, Dr. Rebecca Sedlock from Community Behavioral Health, Katie Cardone from Community Behavioral Health, Rhiannon Fisher from Perform Care, and Sierra Payne from Carelon Behavioral Health. So today's discussion is informed by themes and observations identified through Pennsylvania's 11 and 15 demonstration, residential reviews, and planning for the upcoming ambulatory review process. It's intended to support providers' understanding of clinical practice and documentation expectations, and it's not intended to address necessarily individual behavioral health MCO audit or utilization review activities. Just wanted to make sure that we threw that disclaimer out there. Our September technical assistance webinar will focus specifically on those ambulatory review updates and what providers can expect moving forward. Pennsylvania does remain subject to Act 70, which requires alignment of the ASAM 3rd edition criteria. So as a result, the information being shared today will focus on the 3rd edition and current Pennsylvania requirements. So next, Amanda Madison from DDAP has a couple poll questions.
Good morning, everyone. Our first poll, please tell us your role. Are you an executive director, clinical supervisor, counselor, administration, medical staff, support staff, case manager with DDAP, an SCA, or an MCO? If your chat is not working, feel free to tell us your role in the chat. All right, looks like we have just over about 100 some responses. Looks like a large portion, clinical directors and SCA and MCOs. Thank you. Next, our poll question. What is the most challenging aspect to create individualized person-centered care? A, we don't have enough training. B, we do not have enough time. C, we do not have enough staff. Or D, we don't have enough funding. It's like we have a little over 90 responses. Looks like we're kind of split with not enough funding, enough time, or enough staff. And without further ado, I'm going to hand the presentation over to Anita Kelly from Magellan Healthcare.
Thank you so much. Welcome, everyone. And before I get started, I just wanted to say really thank you to all of the providers in the state of PA who are really making a fantastic attempt and are really making the changes from PCPC to ASAM. It's not an easy task. It was not an easy ask in the very beginning. And many areas are more difficult than others, but we appreciate all of the hard work that you all are doing and supporting all of our members. So if you wouldn't mind, next slide, please. So I'm tasked with talking about client-driven care. And these are three areas that I think are so important to client-driven care. Program-driven versus individualized care, the use of natural supports and incorporating family help in the service plans that you do, and aligning the services and the goals that you set up with this stage of change that the member seems to be in. We often hear when we talk about stages of change, we often hear folks throw around the term, meet the client where they're at. And this is not always easy to do, but the stages of change really help us to put that phrase into action. So next slide, please. So when we talk about client-driven care, there are really some key features that we have to incorporate, right? And I think this is one of the more difficult things that I see when I do the ASAM alignment reviews, is that it's difficult to make that change from program-driven care to client-driven care. When PCPC was being used, everything was really geared toward the client fitting into the program that was developed, right? So we had, the clients were kind of passive in their role. It was a pre-designed program, limited flexibility, and it was really all led by the system. So the client had to move through the system, right? When we talk about client-driven care, the client really has a more active role in decision-making. Even from the very beginning, the client should play a role in that whole assessment process where the level of care is being determined. We want, if the client maybe you think is more suited for a 3.5, but they're saying, hey, I have 5 kids at home. There is no way I can leave them. So, we want to be flexible, and we want to provide a different level of care, like an IOP or a partial, and maybe that's more suitable to the client's needs at this time, right? Care plans should be individualized. You know, we don't want a standard care plan. And when you're looking at individualized care, you're taking into consideration those individual needs of the client. So those are incorporated into their treatment plan, right? We emphasize autonomy, dignity, and empowerment. We want to really empower our members to play an active role, and kind of determine where they want their their treatment to go, right? And we want to focus on what matters to the client, not just like what we're seeing in the assessment, not what is wrong, but how can we enhance their positive attributes, their skills, their strengths. So we want to focus on the whole person, really. And again, I go back to, um, client-driven care is flexible and adaptable. It's not about, hey, you need to be here for this amount of time because this is what the program is all about. It's about, well, I may need to be in 3.5 for a week or 2 weeks, just to say get a boost of 3.5 level of care, and then move on. And so that means that if someone's there for a week or 14 days, 16 days, that means that the program has to be adaptable, right, to meet those client needs. It's just not a cookie cutter program. Next slide, please. One of the things that ASAM really stresses is the importance of incorporating family services into the treatment regime. And if you recall, the Pennsylvania addendum to ASAM really stresses the importance of incorporating family services, right? So, you know, what when we look at assessing family or maybe their natural support system, that needs to start at intake, right? So, what is the nature of their relationships? That needs to be examined in that assessment period, right? How can we use those support systems to help our clients, right? Those are things that sometimes are overlooked. We overlooked the importance of family services, right? And sometimes we need to really tailor the involvement of the client needs and their safety concerns, right? We don't want to involve family members who may be detrimental to the client's treatment, or maybe have been involved in some kind of maybe physical altercations in the past. That is not healthy, and we don't want to involve those folks in the client's treatment. And the client probably doesn't want that either, right? One of the key things that we often don't see is consent forms signed before involving family members, right? That's so important that we do that just as if we were getting the consent for anyone else. If you're getting the consent for Magellan or Caroline, you need to, just as you would do that, you need to get the consent for the family member, right? And sometimes family members will come to you and say, hey, we want to be involved. We need help in working with our loved one, but your client is saying, no, I don't want them involved. So in those situations, ASAM is saying you must provide a referral to the family member So in those situations, you should have a list of family services within your area, or have one of your case managers provide a list within the area where the family is geographically located, right? That's so important. And we know that that will help the client when they leave your facility. Okay, next slide, please. This is another aspect that is so important, and this is something that really enhances care when we accurately apply the use of the social or the stages of change. So one of the things that I think we often see is that the intervention is not matched to the stage of change that the client is in. For instance, if the client is in a pre-contemplative stage of change and the goal on the treatment plan is to identify relapse triggers, you know, that client is thinking, what are you talking about? Triggers, like what are you talking about? I'm not seriously doing this. I'm just here because someone told me to come here, but I'm not thinking about triggers. I'm not thinking about any of this. So that goal, that intervention is not going to help that client where they're at right now, right? And so it's really important to reassess the goals as the stage of change changes for that client as they move through, and perhaps they move from contemplation to action, right? So that's a big step. And the goals that you had lined up and had discussed during the contemplation stage of change are not going to apply during that action stage, right? So those, even though you maybe aren't updating that treatment plan as frequently as the client changes, you still need to review it and address those changes, right? You know, there's a cheat sheet actually that you can get that shows you which stage of change and really what to listen for in that stage of change. And so then you will know more accurately what that client needs within their goal setting. I'm not sure if we're taking questions at this time or if we're saving them for the end.
And, Anita, we were going to save them for the end.
All right, awesome. Well, thank you all. Please save your questions for the end, and I will pass it along to Rebecca, who I believe is our next presenter. Thank you all.
Hi, good morning, everyone. Thank you all for taking the time out of your day to join our call. Very happy to be here to present along with the other MCOs. And I want to echo Anita's sentiment for just being thankful to all of you who have been going through the ASAM implementation and changes through your agency, your receptiveness to the feedback that you've been given regarding some of your policies and procedures and documentation. And we're hoping that today's conversation can help clarify a lot of things that are commonly seen throughout the reviews, and as well as preparing the outpatient providers for things that we're going to be looking for in terms of the reviews. So you can look at this slide, and this I stole it from the DDAP technical assistance call in 2022 that focuses specifically on clinical services. And this chart does a nice job of demonstrating what services are considered clinical across all of the levels of care that are provided for our members. And you can see that these are the levels of care that are not withdrawal management specific. And the reason being is that when you are operating a withdrawal management unit, you still are expected to provide the services listed on this slide for your people who are involved in those services, as well as the withdrawal management services. And so when Anita talked about the transition from the PCPC and how things were a little bit different, under the PCPC, we really focused a lot on Dimension 1 and the withdrawal management part and didn't really focus on the other dimensions. And even under PCPC, we only looked at the first 3 dimensions when we were doing the admission criteria. Under ASAM, all 6 dimensions are important for every level of care, including the withdrawal management levels of care. And so the clinical services need to match the level of care that the person is receiving, as well as all of the interventions that are occurring need to be applicable to help the person move through all 6 dimensions. So we could go to the next slide. And when we're thinking about clinical services, a lot of the times when we were doing the residential reviews, we saw many services that were not clinical in nature. And so we wanted to help establish what is considered clinical versus not clinical. So we have it captured on this chart here. So there are questions to consider as you are providing a service and determining, is this clinical or is this not clinical? So the first question to consider is, can the activity happen without treatment? So that means that if you are providing a service and you think to yourself, I can sit at home and do the same thing without being in treatment, then this is not a clinical service. So that includes watching movies, journaling, filling out worksheets. Those are all things that a person can do whether they're without being in treatment at all. So when we're thinking about what clinical service means, we're thinking about what am I doing as a clinician that is required of an intervention that can only help this person move through recovery in this level of service that I am providing. So if we are running a group for a person or doing an individual session, you're really looking at what intervention is needed by a clinical person that is trained in clinical services to help this person move forward. And if I can't think of what the specific intervention is, then that is not a clinical service. It is something that a person could do as homework, or it is something that the person could do without being in treatment at all. So we really want to focus on what is clinically happening for the individual in terms of that intervention, which moves us into the next question, which is, what evidence-based practice is being used? So as you are doing the intervention during the service that you're providing, you need to think about the evidence-based practice that you are using. And if you're not using any evidence-based practice at all, then that is not a clinical service. When we're talking about evidence-based practices, we are talking about things like motivational interviewing, cognitive behavioral treatment or CBT, dialectical behavioral treatment or DBT, and all of the skills that are associated within those evidence-based practices like thought stopping, challenging negative thoughts, emotion regulation, grounding techniques. All of those things are evidence-based practices. As Anita just talked about with individualizing treatment, the evidence-based practice also needs to be individualized for the person receiving services. So if you're having someone attending a DBT group or doing grounding techniques with them, it really needs to be rooted into that person's treatment plan, which moves us into the third question. How am I addressing the individual's treatment plan? And if I'm not addressing the individual's treatment plan, then it is not a clinical service. And that's why as you are developing your program, there could be lots of groups happening at the same time and giving the individual like a menu of options so that whatever intervention that they're receiving is going to be matching one of their treatment goals, rather than having the treatment goals listed and then the services not matching what is going to help them move through treatment and move into their recovery goals. And then the other question to ask is, can any person run this group regardless of education or title? And if that answer is yes as well, then it is not a clinical service. So if you are showing a movie and you can have a CRS staff or a tech observe the people watching a movie, then that is not a clinical service. If it is journaling, anybody can monitor someone journaling. You don't need to have a clinical degree to watch someone write in a book. So that is also not a clinical service. So it's really thinking through these questions as you are determining, is the service you're providing clinical or not clinical? There's also a quote from the ASAM text, the third edition, that is on the slide, which also emphasizes that attendance at self-help or mutual help meetings, such as AA or NA, volunteer activities, homework assignments involving watching videos, journaling, and workbooks do not represent skilled treatment services for the purpose of daily clinical service hours for each level of care. So ASAM has it outlined very clearly what is also not considered a clinical service. So as you are thinking about the services that you're providing, really focus on what service it is and how it is clinical and how it is helping the individual move through their treatment plan and accomplish their goals. Thank you very much, and I will hand it off to the next presenter. Oh, whoops, we have a poll question. I'll hand it back off to DDAP.
Thank you. Our next question is, authorization period is the same thing as length of stay. True or false? All right, looks like 96% of you say false, about 3% true. And with that, I'm going to pass it to Katie Cardone with Community Behavioral Health. She's going to talk to us about continued stay reviews.
Thanks, Amanda. Good morning, everyone. Like Amanda mentioned, I'm going to talk a little bit about continued stay reviews. So I just want to review the core elements of a continued stay review and what information should be available and shared during a review. I like to think of this as having two key components. It's the ASAM assessment review and the treatment plan review. So those are the two things that really go into a continued stay review. Now, each BMCO might have specific requirements for continued stay reviews that are very nuanced, so I won't get into all of that, but generally across the board, it's the ASAM assessment that's being reviewed and the treatment plan review during a continued stay review. Continued stay reviews are heavily focused on how the member is making progress on their treatment plan, and your ASAM assessment should really drive the creation of that treatment plan. So for this section, and to really set yourself up for success for your continued stay reviews, you want to make sure that you have a good foundational ASAM and a good foundational treatment plan. So I'm going to talk about those things first. In terms of the ASAM assessment, I just want to touch on a few things to keep in mind when you're completing your ASAMs. The first thing, and I think most of us know this by now with the ASAM alignment, but how long the member needs to stay depends on their unique needs that are identified within the ASAM. The length of stay and treatment should definitely vary as opposed to being a fixed length of stay. So gone are the days of those 28-day programs, 30-day programs. The length of stay really should be dictated by that unique member's needs and how they're progressing through their treatment. Within the ASAM assessment, you also want to consider your dimension drivers and your priority dimensions, and make sure that for any needs identified in those dimensions in the ASAM, there's a corresponds to those needs. For example, for level 4 services, that's heavily focused on dimension 2. Those biomedical needs are a priority dimension. So there should definitely be a goal on the treatment plan that corresponds to the member's biomedical needs. And Anita already spoke on the importance of client-driven care, but I just wanted to add that we want to ensure that the goals and the interventions are individualized on the treatment plans, especially as this pertains to continued stay, because when completing a continued stay review, it really is the client's progress on their treatment plan that will be reviewed and what determines the need for continued stay. So we want the ASAM assessment to be individualized as well as their treatment plan. So specifically during a continued stay review, a comprehensive detailed ASAM assessment should be completed for each review, and any updated ASAMs should address progress or lack thereof in each dimension to assess continued need for services. Next slide, please. Okay, so as I mentioned previously, the treatment plan is a core element of a continued stay review. So what we want to know during the review is really what's happening in treatment to show improvement and to resolve the problems that are identified in the ASAM assessment. How's the individual getting better? When the problems identified in the ASAM are resolved, that's typically when the member can be ready for the next level of care. So that's the information that's going to be reviewed during a continued stay review in order to make a decision about whether the member needs to remain in that level of care, whether they need to be transferred, or whether they can be discharged. In terms of progress, in order for continued stay requests to be approved for an existing level of care, we want to see that progress is being made. If progress has not been made, which is typical, the individual could remain in that level of care as long as no new problems arose and they have the ability to make progress. Additionally, there should be documentation of the reasons why no progress has been made, what the treatment team's doing to intervene or address any obstacles there. We know that treatment progress is rarely linear and individuals have complex needs, so it's expected that progress may not always happen. But what should be documented is, is progress possible and how is the lack of progress being addressed? One thing I think that's also important to address, and I think this comes up a lot on the alignment reviews, is what to do as new problems arise. If new problems arise that interfere in treatment at that level of care, that may require you to refer that member to a different level of care, either a higher level of care as needed or a lower level of care. If the problems are not interfering in treatment and it can be managed at that level of care, then the member would remain and continued stay would be approved. I think most importantly, as new problems arise, you want to make sure that the treatment plan is updated to reflect the addition of the newly identified problem. We see this a lot. For example, if a member is sent out medically, they come back, there's this new medical need that's identified. Okay, how's that incorporated in the ESAM assessment? How's that incorporated in the treatment plan? Can that member now be managed at the same level of care? What needs need to be addressed throughout treatment? So definitely wanting to see that a treatment plan is updated after a new problem is identified. And lastly, and this is a common theme here, but treatment plans should be member specific. They should be in their own words as much as possible, and they should address the individual's unique needs. During a continued stay review, the updates should also be member specific and individualized. So you really want to avoid cookie cutter statements like, is identifying triggers, is identifying coping skills. Rather, what's that individual's particular triggers, what are their needs, and how are they being addressed using their unique strengths and their unique abilities. Next slide, please. Okay, so just to summarize, service decisions, again, are really made on progress and that individual's progress on their treatment plan. So does the member need more time? Are they ready for discharge? Should they be transferred to a different level of care? All of these decisions are based on three things: the multidimensional ASAM assessment, the individualized treatment plan, and the degree that the treatment plan is working. So that's it for me. I'll pass it back to Dita.
Thank you, Katie. Next, we have Rhiannon Fisher from Perform Care.
Hi, good morning, everyone. If we want to go to the next slide, I'm going to be talking about aspects of an appropriate discharge plan and discharge planning in general. As we kind of heard throughout this presentation so far, it's really important to include the members' wishes and interests in treatment and discharge planning. So discharge planning is such an important process in the provision and treatment planning and really should be guided by those ASAM assessments that we had just spoken about for continued stay reviews, but also with member input. And discussions related to next steps really should begin at admission. When that member is coming into treatment, those discharge planning discussions should start. Really discussing what the member is thinking of in a multitude of different areas, and then embedding what you guys are seeing in those ASAM assessments during continued stay reviews or those treatment plan updates as well. As we know, these discharge areas can include housing, treatment support, community resources, physical health needs, mental health needs, and any additional social determinants of health needs as well. Each of these areas should be adequately assessed and addressed through the treatment plan and should be updated as needs might arise or change throughout treatment. Oftentimes, as you know, our members are arriving to treatment with mental health needs. That could be anxiety, depression, psychosis. It's important not to only meet the member where they're at regarding their interest and connection to any of those mental health supports, but also ensure that we're providing ample psychoeducation on recommendations. And that could range from medications that could assist with symptom management to various services, including that mental health outpatient therapy, ongoing medication management, targeted case management through their home county, and including peer support services. As treatment needs are identified throughout assessments that are completed, opportunity should be taken at each available step in treatment to discuss evidence-based practices and supports. This could and should include, if appropriate, the education and initiation of MAT, and then connection to continued MAT support and services, education and referrals to certified recovery specialists, and education on contingency management. Connection to physical health supports is also a really important aspect of the discharge plan. This could range to connecting a member with no identified physical health needs to their PCP, just for those yearly annual exams. Connecting a member with diabetes to their endocrinologist and PCP. And the key here is with secured appointments after discharge, just to ensure that they are having that secured appointment to follow up. And this could also range to connecting a member with a range of medical needs to their physical health MCO, our partners, to determine if a connection to care management would need to be made. Next slide. In completing discharge planning with members, there's a few tips that can be helpful to ensure a smooth and safe discharge plan. I always want to highlight that you can feel free to reach out to the member's BH-MCO outside of continued stay review dates to obtain any information regarding network options, community resources that might be available, and even information related to previous treatment stays, what may have worked prior for that member, what might not have worked prior for that member. Many of our MCOs have care managers as well as utilization management staff that can assist with resource identification and even support the member while they're in treatment and when they're discharged back to the community. A really important thing to remember is transportation connection post-treatment. A lot of our folks have limited access to transportation, do rely on public transportation or even walking sometimes. So we always encourage referrals to the county's medical assistant transport program, or also known as MATP, to start while the member's in treatment. If you're familiar with those applications, most have a physician form that needs to be completed. And for those members that might not have a family doctor or other treating physician, that step could be missed if they return to the community and don't have access to that. So to ensure access post-treatment, that timely MATP referral with support of the physician can be made just to ensure that the member has access to that door-to-door transportation for their scheduled aftercare. Some managed care organizations also might have additional transportation resources or information to provide, so outreach can occur there as well. Regarding coordination with care management through the BH-MCO, and speaking for Perform Care, we have multiple care management programs or tracks that members could access. And when a care manager is assigned, we often reach out to the assigned counselor or case manager on the unit to begin to collaborate and provide collateral. We often request team meetings to include the member to meet them where they're at, to provide support and gauge interest in any additional support. We can always assist with education and encouragement as well for next levels of care or connection to those evidence-based practices we've spoken about. Oftentimes as well, our care managers are reaching out directly to the member post-treatment to ensure access to scheduled appointments, as well as assess and address any additional issues that might have arisen post-treatment as well. I also want to bring attention to the importance of documentation in all discussions around discharge planning and aftercare coordination. If a social determinant of health need was identified at admission, say housing or that transportation, there should be documentation to support what was identified to close that gap and what referrals were made if appropriate, or even declination of that recommendation that you guys provided. If after doing an ASAM assessment, IOP is indicated, there should be documentation related to that recommended level of care, discussion with the member on interest of that recommendation, and documentation of referrals, including location, date, and follow-up. I'll now pass it over to Sierra, who will discuss documentation expectations further. Thank you.
Good morning, everyone, and thank you again for being here. I'm going to tie it all together to discuss documentation that we're looking for, especially when we're going out and doing those ASAM reviews. There's 4 main things that we're looking for that really drive quality care when it comes to documentation, and that's medical necessity, individualized care, progress over time, and ASAM alignment. For medical necessity, at its core, this is about clearly telling the clinical story. We want to make sure the diagnosis is specific and supported by the assessment and directly ties to the member's symptoms. From there, we need to see impact. How is this condition affecting their daily life, including work, relationships, self-care? We also need to clearly see risk, like safety concerns, withdrawal risk, medical complications. And finally, we need to explain what's driving all of this. Any stressors, triggers, or underlying conditions contributing to the need for treatment. Next, for the individualized care, we've talked about this multiple times throughout the presentation. This is where we want to move away from generic documentation and really focus on the person in front of you. The record should reflect who they are, their history, their strengths, and their preferences. It's also important to include their voice when possible, so using quotes of things they might say, using I statements. Most importantly, we need to see that the care being provided is tailored specifically to their needs and goals, and not something that when we're reading the record could apply to anyone else that's in your care. The third area for progress over time, every note should tell us if the member is improving, staying the same, or declining. We want to track progress toward goals using clear, observable examples. And at the same time, we need to identify any barriers that might be getting in the way, whether that's environmental, medical, engagement related, such as not attending groups or not really engaging in individual sessions. Ongoing risk should always be reassessed, and we should see how the member is responding to treatment, including what's working and what's not. Based on that, the treatment plan should be updated as needed with a clear rationale for why. And finally, ASAM alignment. This is about making sure the level of care recommendation clearly matches the clinical assessment. And what we're really looking for is to see if all 6 ASAM dimensions are addressed and if it provides a complete picture of the member's needs. Each dimension should include a clear severity rating and a rationale so it's easy to understand the risk and why a specific level of care is being recommended. Next slide. Next, everyone's favorite, treatment planning, and we're always looking for those SMART goals. At a high level, every goal should be specific, measurable, achievable, relevant, and time-bound, and most importantly, clearly tied to the member's identified needs. So I have 2 examples on this slide. The first example relates to recurrence of use prevention. I will develop and follow a personalized relapse prevention plan, including identifying triggers and coping strategies over the next 30 days. So here, this goal is focused on member developing and following a personalized relapse prevention plan over the next 30 days. The key point is that it isn't just a vague intention. This is specific to identifying their triggers and coping strategies, so we know what they're doing to have this recurrence of use prevention. We're also measuring progress by looking at adherence and effectiveness, which can be done through using tools like daily reflection or the counselor review. It's realistic and directly connects to reducing risk of relapse. And finally, it's time-bound. It clearly states over the next 30-day time frame, and you're able to do ongoing evaluation with that. The next example is MOUD adherence. So in this case, we're looking at a goal for the member to take their medication as prescribed in a residential setting of care over the next 30 days. So again, it's specific and measurable. Adherence can be verified using the medication administration records. It's achievable because they're in a structured, supervised setting, so we know that someone is making sure that they're getting their medications and able to document if they decide not to take their medications that day. And it's relevant because it directly supports treatment stability and reduces withdrawal symptoms. And like the first example, it's time bound with a defined 30-day target and review point. So when you're thinking about SMART goals, the main takeaway is you're not just documenting what you hope will happen, you're clearly defining what success will look like, how it's measured, and over what time frame. Next slide. So when we're looking at group notes, at the high level, every progress note should do three things: clearly connect back to the treatment plan, capture the member's voice, and support continuity of care from one session to the next. So starting with the individual progress note, each note needs to tie directly back to the treatment plan goals. We want to clearly see whether the member is making progress, staying the same, or having any kind of regression. We also need to see documentation on what was done and how they responded. That means the intervention used should be named, and there should be a described observable behavior, not just a general statement of they listened or they talked to the therapist. We really want to know what came out of that session. What did they show you? What did they say in response to the interventions that you used? Another key piece is capturing the member's voice using, again, direct quotes or I statements. This really helps show engagement and keeps the documentation person-centered. We should also see how risk is assessed. At every encounter, if anything's changed, it should be clearly documented along with any updates to safety planning. Again, if they say you found out that they're having medical conditions, that should be documented. And then even note, going to follow up with PCP at discharge. At least something to say, we identified this need they had, and this is what we're going to do as next steps. Everything should be clearly documented, and each note should support medical necessity by reinforcing, again, that diagnosis. How is it impairing their functionality? Is there a need for continued treatment, or do they need to go to a higher level of care or a lower level of care? And then shifting to the progress notes for groups. First, we need to clearly identify the group topic and goals for that session. What was the focus? What skills or concepts were addressed? Even though it's a group setting, each note still needs to be individualized. You should avoid copy and paste documentation, as each person's participation and response should be unique. We also want to see documentation again of any observable behaviors, level of engagement, how they were interacting with their peers, and any specific contribution to the discussion. It's important to connect group participation back to the member's treatment plan, showing how the group that they attended supported their specific goals and needs. And lastly, we need to see documentation of any safety and clinical concerns. Were there any incidents that came up, any disclosures that were made, or emerging risks that came up during that session? So overall, whether it's individual or group, the goal is the same: clear, specific documentation that tells a clinical story, shows progress, and supports ongoing care. Next slide. So to close, I'm sure many of you have heard of the golden thread in documentation, but I'm going to give you kind of a review of what it is again. So that golden thread is the connection between every part of the clinical story, from assessment to diagnosis, to the treatment plan, to the progress notes, and ultimately the outcome. Every step should clearly connect to the next. On the left side, you'll see examples of what it looks like when that thread is missing. Statements like the client attended and participated, or the client is doing better, they don't really tell us anything meaningful. They don't link back to the treatment plan. They don't describe what actually happened in the session and how you're gauging that they did better, or what they did to show participation. And it doesn't show any measurable progress. So these types of notes could apply to anyone. And so that's where we lose that clinical story. And when we're reviewing the charts, it doesn't really let us know how the member benefited from treatment. On the right side, however, is what it looks like when that thread is followed. So there's clear connections linking to the session back to the ASAM assessment, references specific treatment goals, and it documents observable, measurable progress. The individual's voice is also captured, which again helps keep that documentation person-centered. Most importantly, strong documentation supports medical necessity and continuity of care. It tells a clear, complete story of why treatment is needed, what is being done, and whether it's working. So the main takeaway is every note should connect back to the bigger picture. If someone else picked up the record, they should be able to follow that thread from start to finish without gaps. Every BIMCO should be able to review the same record and read the same story from start to finish. And when that is done well, you're not just documenting what happened, you're telling a clear, defensible clinical story. Thank you.
Thank you so much, everyone, for sharing your expertise regarding all of these topics. We only had one question in the chat, so we're going to try to get through a couple questions. Anita, the question did come through on the Q&A, and I think it ties into question one. Can you elaborate further on what shared decision making looks like in practice? And the question in the Q&A was, how do you involve family when the client refuses to sign a consent for family or only signs for emergency info? Would you be able to kind of touch on both of these questions for us?
Sure, absolutely. So, of course, you cannot involve the family if the client is saying, I do not want them involved in my care. However, if the family does come to you and says, well, we would like some assistance as well, you should be ready to make a referral, regardless of whether your client wants them to be involved or not. You're not breaking confidentiality. You're not saying anything about your client. You're simply making a referral of some family members to a provider in their area. And so in that case, you do not need the client's consent to do that, because again, you're not even acknowledging that the client is in your care. You're simply making a referral. And Gloria, what was the first question? Oh, you're on mute, sorry.
Sorry, I was on mute. Can you elaborate further on what shared decision making looks like in practice if you didn't touch on that yet?
Yes, that is another great question. So shared decision making includes, the client's input into their goals, their treatment planning, and a treatment plan, as some of my colleagues have already described. A treatment plan should not be what I call cookie cutter. It should reflect the individualized needs of a specific client, and their decisions about their care. So you can also use motivational interviewing to help that client see what may be in their best interest, but they may not be at that point that you think they should be at, or be realizing the needs that you think they have. So it's a give and take, and it's sometimes like dangling a carrot in front of them, so that that's what they want. That's the goal that you have for them, but it may not be their goal, right? So you present this, and then kind of lead them into it using MI. if that helps.
Thank you. Rebecca, could you tell us how movies could be incorporated into clinical services?
Sure. Thank you. So when we're thinking about movies in clinical services, showing an entire movie is not a clinical service, but there may be parts of a movie that can be used to emphasize a point or demonstrate a point. So I go back and thinking about grad school and also undergrad, and every class I've ever had about rapport building and communication, they always show the same 5-minute clip from Shrek, which is onions have layers and ogres have layers. And so they're talking about how difficult it is to establish rapport when people have a whole lot going on in their life. And so you have to peel back all of those layers in order to get to the core part of identifying what the problem is and how to help people move forward. And so they use that clip to just emphasize the point, is that there are lots of layers to lots of people, and so you need to get through those layers to get to the bottom of what the issues are and how to best help them. And so that might be a situation where you have a 5-minute clip that really drives home a point that you're trying to make or demonstrate with the other intervention that you're doing. And so when we're thinking about movies, we want to think about maybe a part of a movie, probably not more than 5 to 10 minutes of a clip to demonstrate the point. If you think that a movie is really, really important for the entirety of the movie, then you can, if you offer the movie, that part is not the clinical service. So that is not a billable activity. But if you want to show a movie, by all means, you can show a movie. You just can't bill for it. But then you can process the movie or talk about the key points of the movie. And then that part would be the clinical service if there is an evidence-based practice involved and it relates back to the individual's treatment plan. So you're able to, as Sierra so nicely put it, tie all of that together. Thank you.
Thank you, Rebecca. Dr. Sedlock, I'm sorry. We had one more question in the chat, and it does tie into another question that we had planned to ask. So what if a member repeatedly misses group despite motivational strategies? And that sort of ties into another question we had about what should a residential provider do if someone doesn't attend group, especially if that's the only service offered for the day. We had that for you, Dr. Sedlock, but if you want to address that, or if anyone else has something about the repeatedly misses group despite motivational strategies.
Sure, I'm happy to address that.
So
I think that when we're thinking about the services that are offered in a residential setting, there are 24 hours to offer a session in the day. And so when we look at the person's individualized treatment plan and the individualized service, what we want to think about is what is causing the person to miss that clinical service that day. So is it that the person doesn't want to attend group? Is it that the group is the same time as another activity that the person has, like maybe court or a medical appointment or needs to see a doctor? Or is it that the group isn't appropriate for them and so they don't think that they should be there? Because as Anita talked about the stages of change, sometimes people are attending groups that might not fit into their treatment plan or their stage of change. So thinking about when a person does not attend the scheduled group, thinking about how you can restructure your program to offer more than one service in the day, or can a therapist follow up with an individual session? How are you adapting the treatment plan to ensure that the person is meeting their services for the day? Are you having a conversation with them to find out why they're not attending, and what other options do you have available for that individual? So maybe you offer a group in the morning and then in the afternoon. We know that sometimes in in treatment that people have, that the residential providers have set schedules. And so looking at your schedule itself, and if you have people who maybe are on medications where it's difficult for them to be awake during certain times of the day, maybe not offer group during those times of the day. So how can your program be flexible to meet the individualized needs of the person that is receiving services? Because as we've talked so much today, we really shouldn't be seeing cookie cutter services. We shouldn't be seeing cookie cutter treatment plans. We really need to be individualized. So what is it that that person needs, and how can you engage them to come to treatment? And realistically, if you're using multiple motivational interviewing strategies and the person still isn't willing to attend services, then they are telling you that this isn't the right service for them at this point in their recovery. And so looking at how to help them move forward with transitioning to a different service that would be more appropriate to help them meet their goals. Thank you.
Thank you. Unfortunately, we have run out of time. I just want to let everyone know, we'll take all of the remaining questions, and we'll have a written Q&A later on after we have a chance to review the rest of the questions and prepare written answers for those. So we will provide the answers to the remaining questions. We'll just need some time to get a Q&A up for that. But thank you all for attending today. I think this has been very helpful in hearing the perspectives and expertise of our BMCO partners. Please stay tuned for September 12th. Our next technical assistance webinar is going to be on the 11 and 15 waiver ambulatory review updates. So that'll coincide with information that we talked about today. And finally, we do have a resources page. So once we get this PowerPoint up on our website, and we'll also share it with everybody who attended today, you'll have access to the links to all of the resources from each BMCO provider. So unfortunately, we've run out of time. Have a great Monday, everybody, and a great rest of your summer. And we really hope to see you in September. Thank you.
Thanks, Gloria.